do with the STPs. Okay, may we then move on? Thank you very much, Matthew, to the next item, which is around the new care models and the frameworks for PACS and for the enhanced care and care homes. Ian, over to you.
Thank you very much, Chair. At our July board, we considered the MCP care model, and today I bring the equivalent frameworks for PACS and enhanced health in care homes. These two frameworks assemble together the constituent ingredients of reform from the work of the Vanguard systems, and they now define the models. Nearly all the STPs are planning to develop new models of accountable care provision, whether PACS, MCPs or a combination, along with the expansion of collaborations across acute services. And so they will become core delivery mechanisms for STPs. In some of the smaller STP footprints, a PACS may cover the whole STP. For most, more probably, they will form subgeographies. Both PACS and MCPs involve the fundamental redesign of care. They're about engaging and activating patients and communities, harnessing technology, and making better use of the workforce. Their purpose is to dissolve the partitions between primary, community, acute and social care services backed by new business models. The PACS and MCP care delivery models are almost identical. They differ mainly in the breadth of services in the PACS, which includes the direct delivery of core hospital services. Both take the registered GP list as a starting point, and neither can work without the full engagement of primary care. At the same time, the commissioning of a PACS necessarily involves potential conflicts of interest, and through the commissioning committee we are working through what, if any, additional safeguards may be required beyond those already set out in our statutory guidance and the consultation document that you've just alluded to. We are seeing some impressive individual examples of change in the vanguards that are beginning to make a demonstrable difference in moderating demand and improving the efficiency of supply. In Mid-Nottinghamshire, the PRISM teams, the integration of social care with acute services in Salford, the emergency care redesign in Northumbria, the management of high-need, high-cost patients in Yeovil. The task now is the systematic implementation of all elements of the framework by all of the PACS vanguards. Care redesign is the critical task, but it does also need to be backed up by new commissioning and contractual arrangements. As with MCPs, we see three options: a virtual PACS, a partially integrated model, and a fully integrated model. With NHSI, we have been developing a joint assurance process, which will consider both the management of risk by the new providers as well as the effectiveness of the ongoing commissioner function. And we'll be taking this through the next meeting of the commissioning committee and seeking to publish that in October, as Simon referred. It's worth noting that with the fully integrated commissioning model for a PACS, it does imply a significant redrawing of the boundary between what will continue to be the commissioning function and what is accountable provision. The mandate commits NHSEngland to achieving at least 50% of the country having coverage of new care models by 2020, and as Simon mentioned, we will be drawing up investment proposals for spread from 2017-18 in the light of STP submissions. If I could now turn to enhanced health in care homes. This is, I think, a much neglected area, and it's been fantastic to see the levels of enthusiasm and engagement from the NHS, local government, the voluntary sector and the care home provision in trying to work this through, improve the quality of life for residents, support for staff in care homes, as well as tackle some of the frustrations that the NHS experiences as a result of the interface not being well addressed. So it's a potential, I think, triple win there for staff, for patients and the NHS. The Care Home 6, the vanguards, have been developing and implementing the recipe of what works, working this out with their local partners and national bodies. And we are now setting out the 7 core elements and 18 constituent sub-elements, including a number of low-cost interventions. We think the model is clear, and many of the individual elements are well known and based on pre-existing evidence, professional best practice, and NICE guidance. Of the elements, I particularly highlight the importance of the first, which is around achieving effective and enhanced primary care support. We're seeing early results, reduction in falls, lower prescribing costs, reduced ambulance conveyances, and fewer avoidable admissions. The novelty of the care model vanguards, though, lies in the systematic implementation of all of the elements in combination, and us then to be able to understand what the full effect of that will be. We see significant interest across the country in adopting this model, and scope for more rapid national rollout of this model, given its narrower focus than the whole population models of MCPs and PACS. And so later this year, we're intending to set out plans for national rollout. Chair, I commend both of these frameworks to the board.
Ian, thank you. Let me now invite Wendy, please.
Yes, obviously new care models are central to our success going forward. And the care home work is excellent, has a number of really compelling points to it. My question is about the PACS, and if I'm an average everyday patient or citizen, what is it really going to mean for me? What's going to be different? How am I going to feel the NHS different?
I think at the heart of both the MCPs and the PACS is really designing the care around the needs of individual patients. So rather than having, you going to your GP for 10 minutes, irrespective of whether you've got multiple long-term conditions or actually you're normally well, what these models are doing is by looking at the totality of primary and community services and some of the hospital services, they're designing what's really needed for different groups of patients. So this means in someone like Yeovil, the frail elderly service, you've got a comprehensive assessment that's proactive. You've got teams of a geriatrician and the GP working with the pharmacist, visiting you in your home and providing much more intense follow-up. It must make intuitive sense where you've got high need, high cost patients for the NHS to put its efforts behind that.
I have Moira and Michelle. Moira.
Thanks, Chair. For transparency, can I restate my declared interest as Chair of Skills for Care, the Workforce Development Agency for the social care sector. I wanted particularly to welcome the Enhanced Health in Care Homes paper. It's great that the NHS is recognising that residents of care homes have every right to the health care that any other citizen expects. The advantages, as Ian said, for the NHS are obvious. And it leads me to the question of why haven't we done it before? And the answer is, of course, that it's the health and social care divide that we all struggle with, but that it's complex and it won't be easy to implement. Although it sounds deeply obvious, it won't be easy to implement. And I just wanted to, in both celebrating the achievement in the paper, encourage colleagues to really emphasise that this isn't being done to the social care sector, but done with. Obviously, it's there's a lot of work for the NHS to do, but it can't succeed if it isn't done on a collaborative basis. And sometimes the language and sometimes the emphasis is very NHSy and not as collaborative as it needs to be. So I wish it well, but I think that that's an important point to make.
Moira, I think you make an incredibly important point. This will only work if it's through an effective collaboration between the health partners and the local authority partners, and indeed the care homes providers, who have a critical role here in supporting the delivery of the model. On your first point as to why this hasn't happened before, yes, it is complex and it won't be easy. However, my contention is that one of the reasons why this hasn't happened before is because of a lack of focus. And we haven't had the examples of people implementing the different elements together and beginning to understand the effects and the benefits that can arise from that. So I am optimistic that we can actually roll this out in 2017-18, to do so at pace and at scale, and see some of the benefits begin to accrue soon thereafter.
The evidence does seem to quite clearly support the hypothesis on which we launched the programme. I think it's very, very, very strong evidence as to the impact. I have Michelle and John and David. Michelle.
Thank you. Ian, could you just talk us through the how you're going to scale and replicate, and what some of the challenges that you will face in doing so?
For both of the models?
Or particularly for the care homes work?
For the care homes work. So there's a variety of different mechanisms we're considering here. One of them is to what extent we can encourage all of the emerging models of accountable care provision to incorporate this as a core element. Mm-hmm. We are seeing this already within, in Rushcliffe in Nottingham. The Principia MCP is already adopting this model. And I think, bearing in mind the direction of travel on STPs, I think that will help. I think we can look at whether some of the elements, or indeed the whole recipe, could be promulgated across CCGs with the support of their partners more fully, and we're exploring that with NHS clinical commissioners. I think, picking up on Moira's point, we can also enlist the support of the care home provider sector, given the importance of the training and upskilling of their staff. And we have interest from a number of the care home chains to participate in those conversations and take an active role in driving this forward.
Also on the care homes initiative, just to remind you, I'm a consultant in Newcastle Hospitals, which is the next door neighbour of Gateshead, so I have a local interest. And what I was just, you alluded to the likely improvement in terms of reduced admissions to hospital. Is there a plan to actually document that in the vanguards and in the rollout? Because I think that would be a huge selling point to the local health community, to actually see that drop as opposed to anticipated or predicted.
Yes, exactly so. And we have a combination of both local evaluation work and national evaluation work that is looking at where the different costs arise from implementing the model and the different benefits as well. In terms of the taxonomy of benefits, we think that there will be potentially a one-off step change, as well as potential ongoing kind of run rate reductions. Probably the easiest element to get at is in avoidable prescribing costs. We are also then seeing some reductions in avoidable admissions and ambulance conveyances. There is some variation between the different 6 sites at the moment, and that's partly to do with the fact that they have not yet all fully implemented all of the elements. And have started from different starting points. And it's worth remembering that when we're thinking about wider spread, we will neither incur the full costs of implementing all of the elements from scratch, nor indeed achieve the full benefits, because this isn't a greenfield site. The NHS and the care home sector has already been implementing different parts of the model already.
Thank you, Malcolm. Ian, mine is on the PACS model, and it's more about the balance between, on the one hand, the need to continue the joint working that exists between local GPs, local health systems, trusts, etc. And on the other hand, the need for transparency and for confidence around procurement decisions. And that procurement decision picks up what Simon said earlier about, you know, some of these contracts will be big and multi-year, and therefore will require some of the insights that you were talking about coming out earlier with yourself and NHSI, but also there's a conflict of interest point, and your paper alludes to it in 3.10, but I guess I think it's our duty to provide probably a bit more guidance than I think is implicit in what is in your note, to help, as Malcolm said before, to keep people safe as much as for, you know, sort of trying to get in the way of doing these things. So I'd be interested to know about where we are in that thinking. There's clearly a tension and a trade-off, but I'd be interested to know how we're thinking about this, what we're intending to do.
You raise a critically important point, David, and it's one that our local systems raise with us because they would like to see some national advice and guidance on this to make their task easier. We are working intensively with 6 systems on developing the new contractual models for MCPs, but we also have some of the PAC systems, Northumbria and Yeovil most obviously, who've been looking to go through significant procurements. Our task here, I think, is to make sure that we can enable those systems to move at the pace they want to go. So that's why I think the conversation that we will have at the next commissioning committee on kind of nailing down the best practical way of doing this in terms of when people excuse themselves from the conversations around procurement because they have an interest in being potentially part of the provider, how that actually works through in practice, but in such a way that doesn't harm the necessary collaboration between the GPs and the other potential providers.
I think that's a very, very good way of putting it. We are responsible for putting these people into a situation where there is an institutionalized potential conflict of interest. There is a good reason for doing that, but there's every good reason for not going over the top and being punctilious, but there's every good reason for having clear principles, allowing people a safe area in which they can take decisions without threat of a perceived conflict of interest or of any other challenge. Victor?
Thinking about the role of the not-for-profit sector, you declared my interest earlier, I run one, but particularly in relation to people with complex needs, and I should declare I'm the chair of the APPG on complex needs dual diagnosis, and I'm just wondering what your thoughts are around the engagement of service providers and that are going to be pretty critical to some of these complex needs, the notion of community-based care and preventing people from going to hospital. And I just wondered whether you could say a bit more about, well, concerns you have, or indeed notes for celebration in terms of the PAC's engagement with the not-for-profit sector and the ways in, because it's a bit light on that.
So within the framework, we highlight a few examples. I will particularly pick up on your notes for celebration, Victor, because I have been very encouraged indeed by the extent to which the PACs and indeed the MCPs have been thinking much more openly than I have seen across perhaps typically the rest of the NHS in how they work with the voluntary sector and how they look at the role of carers. How do they change the boundary between formal care done to people and informal care, the working with their local communities. There are numerous examples in mental health in Frimley Park, the engagement of Age UK, but the systematic creation of social prescribing models and connection through to, in a really organised way, of lots of voluntary sector partners through these models. And I'm sure we can do more to bring those examples of best practice out more fully. And we're actually working with the Academy of Fabulous Stuff in the next few weeks to try and highlight some of those examples of good practice. I think one of the elements of caution is going to be with the wider rollout at pace of some of these models. A lot of the STPs are placing quite significant store on the importance of fundamental care redesign, and there will be a challenge between the pace at which they aspire to go and the need to build those partnerships with their local communities. So I suspect this will be less of an issue about the initial vanguard wave than how do we really make sure that we embed that mindset and those practices within the kind of, when we get to 50% of the country. And I think your reminder is a very timely and important one.
Okay, well, thank you, Ian, very much for the paper. I'm going to invite the board to not only note the paper, but also to endorse the framework documents that are part of this paper. We're content to do that? Good. Thank you very much.